Hello. Today we're going to talk about patient and family experience and quality and safety in healthcare. And up to this point, we have talked about the patient kind of in a remote sense. We've talked a lot about workplace safety. We've talked about patient safety science. Of course, patient is the key word in patient safety. And of course, in quality, we're measuring patient outcomes. But one thing that we can never forget is a patient is a part of the healthcare team, and we just can't leave the patient out. In old times, and we talked about this in ethics, there is a real paternalistic viewpoint about patients and the healthcare, particularly the physician patient relationship, where basically the patient listened and did exactly what the physician said, and the nurse, the healthcare team as well. And now it's more of a team member piece, although uh, often healthcare providers do have those paternalistic feelings. And of course, we get into all kinds of ethical issues when patients can consent and make their own decisions. However, in any aspect, the patient is a part of quality and safety, and often we leave them out of the discussion. So today we're going to talk a little bit about some basic concepts in patient and family experience. So first of all, this is adapted from the Picker Institute, and basically is the basis for many of the different initiatives around patient and family engagement, or PFE. And basically, they said improving healthcare through the eyes of the patient includes effective treatment delivered by trusted staff, involvement in decisions, and respect for patient preferences, fast access to reliable healthcare advice, info, and support for self care, physical comfort in a clean, safe environment, empathy and emotional support, involvement of family and friends, and continuity of care and smooth transitions. Sounds really easy, but we've seen in much of the material we've studied this semester, and then through your own experiences in clinical settings and personal too, we probably have had several experiences, either through us or our family members, where we really haven't had some of those things to the best of our ability. So, for example, we looked at some of the quality metrics that are measured, and one is the clean, safe environment. And we see that some of the patients don't think they are in one. Some people don't have access to reliable health care. And the list goes on. So, especially when you look at continuity of care and smooth transitions and patient safety, that's huge. So these are just some. It's kind of like the basic bill of rights. Now, patient family engagement, and we do talk a lot about hospitals. That's where a lot of the work originated. But you do have to look at all healthcare settings. So when you look at the location, this is a useful uh, graphic, and it's from IHI, and it talks about the environment, the community, region, and state, and how health we reach patients through healthcare. And you've seen some of the community groups that the Near North Side works with, and elsewhere too, school and church programs, public health, all sorts of things. There's an article in the paper today about reaching kids for school lunches, things like that. Organization is more at the system level. So that would be your major hospital systems, long-term care. Another way to more directly reach the patient, and some of the examples that they give are experience surveys and patient complaints, things like that, the access that patients need. The microsystem is the particular clinic, the ward, the emergency department, and delivery. And the individual experience of care is that little area right by the bed, basically, the bedside, the exam room, the home. So a useful way to um, visualize this, for me anyway, is through this graphic, and you can see the environment, the organization, everything nests together. And I think sometimes when we are, for example, providing care in a clinic or in the patient room, we just see that little area. And that's why it's so important to consider the holistic aspects of care, where the patient's going. In the hospitals and clinics, we just see patients for a snapshot of time. So it's so important to figure out what the patient support system is, where they live, different resources that can be available to them. So I think this actually, when you look at this graphic, it's true for many things, but it is very adaptable to patient-family experience. So one thing, and this is from one of your readings, we know patient-family experience is the right thing to do, and we assume when a clinician engages patients and their families as active members of care, that we add details to the patient record. Patient family recognize and speak up about patient care errors. They're more likely to participate and adhere to plans if they can help make care decisions. And they can serve as advisors, helping to improve the overall patient experience. Now, there's evidence out there, but there's no one way to ensure patient family experience. And when you think about the busy environment, that blue slide that we looked at with work complexity, where the nurse is trying to give the IV fluids and all the different things are happening, it's the same thing for patients too, from their experience. So patient family engagement is a challenge in a busy healthcare environment. Key practices are organizational practices. So sometimes you'll see patient advisory councils in the community, access to issues, disclosure, which we've talked about, is one patient family experience um, initiative that has some literature around it. Bedside practices with whiteboards, access to information and shared decision making. So these, and so health literacy, all of those things. And so these are the key practices that you see. And in healthcare, also from the Heron article, and I think this is true, the most commonly implemented PFE initiatives are visitor access, disclosure, and we talked a little bit about that, then patient safety advisory councils. Now, it's interesting, and when COVID-19 emerged on the scene, it really changed the way we practice care in a lot of instances where patients couldn't have visitors. And we saw many of those just heartbreaking stories in the paper or on TV about loved ones dying alone, nurses holding hands, and in some cases, uh, many cases, nurses and healthcare providers had to just go in and out and not spend a lot of time with these ill patients. So that's one initiative for patient family experience that really took a hit during COVID-19. And you saw all kinds of creative ways healthcare providers were trying to reach patients. And it was so sad. Some of the patients in long-term care facilities where their families had to visit outside windows, and of course, you always worry about disorientation and things like that with older folks. So there were some creative ways around visitor access, but that is one sort of tried and true piece that really didn't work very well in this current era. So here are some barriers to patient family experience: competing organizational priorities. So, for example, with COVID-19, we were worried about staffing and caring for patients and the virus. So that decreased the usual access. Sometimes it takes time to set up these programs. So patient advisory councils are very time intensive because you need to reach people in the community, try to figure out meetings. Now with some of the restrictions, you'd have to do some Zoom meetings or something like that. Very challenging even in normal times. There has to be time available for rounds and shift changes, so that time has to be allotted. There has to be some transparency for cost information, and actually, there was just a ruling that costs now of healthcare are going to be more transparent, so that will be interesting to watch. The availability of clinical information systems, probably this is one of the strongest areas, although still there's lots and lots of challenges. Support for PFE from clinicians. Sometimes it's not the most efficient way to go to spend time with a patient, or to do some of these extra things. And maybe clinicians don't have that capacity or time. So it's, competing priorities as in the first bullet. And then the patient has to be willing to participate in care too. You will see patients who are very willing. You'll also see patients who want nothing to do with the healthcare system. So, as we talked about, the patient's a member of the healthcare team. The patient actually does have to participate in some way. Now, there's some challenges around patients and providers for patient safety purposes. One is patients with limited English proficiency. When you think about the informed consent, it's a very technical document, and even if English is your first language, patients don't. Well, I don't want to say often, but there are many times that patients don't fully understand what's going on in informed consent. Sometimes they don't want to listen because they just think their doctor knows best. And using interpreters does help. But sometimes when an interpreter is on the phone and maybe it's a elderly person who isn't tracking very well, there's all sorts of challenges around that. And then sometimes patients do contribute to error, sometimes around compliance, or sometimes like provider areas, they're dealing with complexity too. They may be juggling different doctor's appointments and medicines and maybe getting conflicted advice. I think sometimes that happens where there's not good coordination of care. I urge you to take a look at Toni Cradell's story. Toni is a very articulate woman who had low health literacy. She couldn't read or write, and you would never know it to talk to her. So do listen to her story, because it's not always apparent who patients with limited health literacy are. You would, by all appearances, you would expect her, to be a person who could read and write, very intelligent woman. So take a look at her story. And then also take a look at Don Berwick. And, we looked at that escape fire. And this is the video of him describing his wife's healthcare journey and some of the issues that they experienced. And these are two educated people. So when you look at this, think about Toni, and she's an incredibly intelligent woman. I've met her and sat on panels with her. She hid her illiteracy due to shame. How can you, as a nurse or health provider, ensure that your patients are able to process and participate in care? And then contemplate Ann Berwick's care. Is it unusual or something you experience, or you've seen, or experienced? And what would have helped her? And then finally, I think in the era of COVID-19, we're going to have to rethink some of these things, at least for the next year or so, just as we are in education and other areas. Patient family experience is very important. Patients are a member of the team. Sometimes we're patients too, and we want to be a member of the team as